pandemic, that we could have better outcomes, less disease, less deaths in pandemic if we focus more on diet and exercise. And I got shadow banned on Instagram for this, and had outrage from my medical colleagues by suggesting this controversial thought, this wrong think. But it is well known that the glycemic variability is an independent risk factor of cardiovascular disease and death. And even the American Diabetic Association looked back as far as 2005 on the research and identified this. So why does the USDA, ADA, AMA still suggest this food pyramid diet, or this 60% carbohydrate energy diet and low protein, so 12% protein? And even at A4M, if we go to these conferences, we hear routinely low protein diets for longevity and so forth. This is often based on poor epidemiological studies. So for the most part of this lecture, I want to look at interventional studies. Okay, so here they did 11 DM2 and 11 normal glycemic patients in this study, and their diet was tracked with the CGM, a continuous glucose monitor. And they looked at what would happen when you put them on this standard diet that is recommended by all these agencies. What you saw here in the big spike, this one up here, this is the diabetic patient who ate this standard evidence-based diet of 60% carbohydrates. They had a massive spike in glucose. You may not be familiar with these numbers, but 5.5 nanomoles is equal to 100 milligrams per deciliter, which is what we're accustomed to. So you can see massive spike with breakfast in the diabetics. Now, the normal glycemic patient, they could tolerate this to some degree. They still had a spike, but nothing like what the diabetic was experiencing. This, when we go to the primary care, we say, well, you're getting these spikes in the blood sugar, the A1C is high. Well, let's put you on the metformin. That's the first drug they go to. However, metformin will not control the hyperglycemia, and these type 2 diabetics will experience 13 hours a day of the hyperglycemia. I point out this picture because it's from the 50s. This was promoted as a healthier alternative, heart-healthy diet. Lots of carbohydrate in the morning, oats, cooked oats, which spikes the blood sugar. And this is not very good for the diabetic, despite being recommended as heart healthy. So the CGM is also a better marker than fasting plasma glucose and the A1C. You can apply this easily to both the non-diabetic and the diabetic patient, and you can observe this for your own patients in real time. But you will find that type 2 diabetes patients spend a lot of time in hyperglycemia throughout the day when they follow this evidence-based recommendation of 60% carbohydrate diet. The fasting insulin is one marker I routinely check in my patients, and I found that this correlates very closely with optimal CGM control, as well as an A1C. We'll look a little bit later what it looks like in a highly athletic population wearing these CGMs and what an insulin might look like. Oops. But first, let's talk about what we're actually seeing in CGMs, because we're going to look at a lot of CGM data here. Your glucose meter will read perhaps 100 milligrams per deciliter, but your Dexcom device or Freestyle Libre device, it may not match as closely as this, and it may fluctuate between 80 and 120 milligrams per deciliter. So they considered this okay because it measures some interstitial fluid space. They considered it okay if it's off by about 20%. So just take that with a grain of salt when you're looking at these. So this is my mom. She used the CGM for about a week. She didn't calibrate it perfectly, and she logged it in a Word document, and she learned very quickly what was happening. And she's a very thin woman. She thinks she eats very healthily, but she learned pretty quickly that she didn't tolerate the carbohydrates too well, specifically the fructose carbohydrates, the bananas. It would shoot her up very high with a banana snack, and she would stay elevated for some times with banana, for instance. But if she ate bacon, beef, tuna, broccoli, mushrooms, she had a little bit of a blood sugar spike, and it would come down pretty quickly afterwards. So
What's the CGM? Can you explain that?
The CGM. Let's get to that a little bit more here. I will show a picture of what this thing looks like. Where is it? This is a CGM. It's on the back of her arm. I don't know if you can see that white device there. That's a CGM. It's a continuous glucose monitoring device. It measures, as we said, interstitial space. It's not a blood sugar reading. So it's not perfect, but it can give you real-time data feedback on the blood sugar variation throughout the day.
How much it cost this system?
This Logan picked this up today. 4 sensors, $114 with was it GoodRx or where was it? Yeah, GoodRx. She went and got this device. So
And it
well,
goes to the watch and your phone? The
yeah, it
data?
goes to your smartphone device, correct. So you can pick this up yourself today.
It measures the sweat, right? The sweat
No,
sugar?
no, no, no. It measures the interstitial space. You plug it into the arm and it measures just below the surface. A little small needle microfilament device insertion.
But it
Yeah.
doesn't have any pain, right? In putting it there.
No, no pain. No
And
pain.
only 114?
Yeah, you can get this for a month, $114. You can also get it with
You gotta learn.
where's you can get it with
This is good for
Signos.
telemedicine program. Is
Oh,
it part of
fantastic.
telemedicine?
Yes, so
Remote
Signos.
control?
Yeah, Signos is a company that sells it directly to patients, and they have a bit of a telehealth assessment component of this too. So non-RX available as well with this. Good deals too if you get it for 6 months. So this is my dad. He also wore the CGM. You can see he's a very fit individual, good muscular build. His normal CGM level was between 90 and 100. If he had 4 ounces of raw milk, it would go up by 25 points and it would drop down within 15 minutes back to normal. He found this repeatedly pretty good. He once ate a lot of mangoes and it went up super high and he felt super dizzy and weird. So he learned a little bit about that. But overall, he's a very metabolically healthy individual. You can see this lines up with his blood work here, A1C 5.4. He has homocysteine 7.1, very good. Glucose 94, insulin-resistant NMR score less than 25 percentile of the population, and a fasting insulin of 3.3, which is very rare to find in most American population. But Dad is a hard worker. He trains hard, and he eats a very strict diet. But insurance doesn't cover this thing routinely, so just keep that in mind when prescribing this to patients. You'll get a lot of prior authorizations and a lot of frustration. So just have the patients pay cash for this. This is my wife. She's bought this thing today. She's going to wear it. She wants to see what will happen. You can see you get some low readings on occasion too. You know, don't worry about those. The CGM device sometimes will read them low when you're training hard. When you get into sauna, which she did today, it will read a little bit lower. But this is her average here as far as today. She eats very healthy. Rump roast, grass-fed beef, bone broth stew, complex carbohydrate, purple tomatoes, carrots, and radish. So very minimal blood sugar variation there. This is something we all have to understand as providers, is that the A1C might be within that reference range, or the fasting blood sugar may be normal. But if you look at interventional studies, in 6 out of 11 patients with type 2 diabetes, hyperglycemia can still be unacceptably high with glucose excursions greater than 10 millimoles per liter in 24 hours. We don't look at A1C as so important when we have a CGM at our disposal here. So Dr. Halasa, you will be very happy to see acarbose made my list here of pharmaceuticals we can use that may be a bit better than metformin. So acarbose was shown in placebo-controlled prospective study to prevent non-insulin dependent diabetes mellitus trial and reduce the risk of diabetes in 36%. What it did also show is it reduced the progression of intermedial thickness in the acarbose group. Acarbose inhibits the carbohydrates from turning into glucose. It seems to improve some, end stage hard endpoints that we look at in these here. Halasa, you'll be offered opportunity to explain a little bit more about your product in a bit.
Well, the thing is that if you do acarbose by itself, it's a problem with bloating and gas. So you really need to have a cocktail, and that's where we're going to talk about it after you finish the lecture.
Yes.
But the CGM is very interesting thing.
Yeah, I'm glad you like it. So
Right.
metformin is a cheap drug. You can still use it, but use it strategically. Whoops. why is it flipping around here? Where's so metformin, how do you best use this? Well, ideally use it before the meal that they eat. They take the metformin, and they should exercise after the meal, which we're going to get into more later on, exercise. But metformin and berberine should be used prior to the meal. But again, wear the CGM, tell your patient to wear it, and observe to see if this is true. Other pharmaceuticals, we are all aware of these fancy GLP-1 drugs. They're very expensive. Pharmacies, don't always have them, and insurance companies never like to cover them. But they are better at improving this glycemic variability. And this is well proven in the big pharma studies. We all know about these drugs, so I won't go into them too much. But I do want to bring up this little interesting bug that we learned about at A4M, the Akkermansia. This was probably the biggest takeaway I had from spending all that time in Las Vegas. This Akkermansia is an anaerobe that lives in the gut microbiome, and it seems to affect the GLP-1 expression and improve the glycemic variability. Now, previously, you couldn't get Akkermansia because it's an anaerobe and oxygen would kill it. And there's one company, Pendulum, found out how to put it into a product so that you can supplement your patients with it. Lo and behold, it can lower postprandial glucose spikes by 33%. It can lower A1C. It's well tolerated, safe drug. So I was very impressed with this data that they presented in at least 3 separate lectures at the conference. It also seems to improve the metabolic syndrome and obesity. We find that populations with leaner physiques have more Akkermansia in their gut microbiome, and the obese patients have less Akkermansia. You can find the Akkermansia naturally in fermented vegetables like the sauerkraut and the kimchi, some of these fermented foods. It also seems to play a role in the cravings that these patients will have for the sweets, the fast foods, the sugars. So I think this is I have a low threshold for prescribing this in my patients now. I'm going to give it a go. So conclusions for at least this part 1 of the glycemic variability series here is that it's an under-recognized and critical factor in preventing mortality and morbidity from cardiovascular disease and COVID-19, and that our standard assessments, A1C, is not good enough. That the CGM may be better to assess this glycemic variability, and that our standard drugs, metformin, is not good enough. Acarbose and GLP-1s and Akkermansia may be a bit better. And we'll get a bit more into nutrition later, but I'll give you a preview and a hint that the ADA and AMA advice of 60% carbohydrate diet is not good, especially for the diabetic. Halasa, I'll give you a moment here to give a plug-in for your product. Yeah. How to make acarbose more tolerable so that people don't have flatulence.
Well, that's why we can add charcoal, activated charcoal. There's many anti-gas medication, but I think Dr. Mike Emanuel is a pharmacist here, and he put together a capsule where he combined acarbose with activated charcoal, with low-dose metformin, with amloxanox, because you need amloxanox. It helps to manage leaky gut syndrome and ulcers in the gut, preventing leaking of the toxins, which is the reason why we have visceral fat. And it has some quercetin, B12. I think I named some of those ingredients, but I think as a combination, you can tackle the weight loss from all different directions, not just pushing the pancreas to produce insulin by semaglutide, which is effective, but at the same time, it can be detrimental if you're using it for a long period of time, because it can lead to oxidative stress in the islets of pancreas, beta cells, and lead to diabetes and putting patients in ICU, and they become full diabetic patients. You don't want to take that risk. So doing it for semaglutide for a short period of time, making sure that the patient has all the detox needed, because when you shrink the body, it leads to toxins accumulated, which can lead to problems. So as long as you're detoxing the body, you're fixing the estrogen dominance as well along with it, because weight gain or obesity, it's linked to estrogen dominance. And if you do that as comprehensive approach, then definitely you can get better result, more healthy results. But
Dr. Halassa,
semaglutide by itself, it may and continue doing it, it may lead to muscle wasting and things like that. So having it for short period of time, it's good. But adding this capsule, which is a cocktail of all those ingredients, it's more safer for using it. It's like a candy. And then also using some probiotic. The probiotic that you mentioned is good, but also the bidiform or a bacteria. There's a bacteria that's also helping weight loss. I think Dr. Hotan has it. With that, along with all this supplements that helps in berberine and others, quercetin, ACGC, polyphenols, and also Dr. Mike Beamer has a very good anti-aging mitochondrial nutrients, which is also a good thing to add. If you get all of this in a protocol, and with time they can wean from the medication, keep up with the supplement, and if they need more medications, in other words, you can go back again with the capsule, and then if they still is not working, then you go back to the injections. But as if you can make the patients free from medication, keeping them with supplement with time, that's the ultimate goal.
Yeah, Thomas Lee, you had a question?
yeah, I did. I didn't think you wanted to mix activated charcoal, a broad adsorbent, with supplements you're trying to absorb.
Yes, there is a challenge there, but if it takes a little bit out of drugs out, and so still there are some drugs in, that's fine. The reason we did activated charcoal is affordable. I did suggest other anti-gas drug to Dr. Mike Emanuel, but I want to take the advantage of the activated charcoal to detox the body, along with doing this. So it's, if we consider activated charcoal, we'll take with it some supplement out, and that's true. But how much percentage is it significant enough to compromise the effect of those drugs that we're putting? Possibly, I don't know exactly that answer, but what I know is that activated charcoal also it's part of the management of obesity, because it helps to clear body from.
Yeah, I use it. I just try and separate it by a couple hours from anything you intend to or want to absorb.
Well, I don't want acarbose to be absorbed. Acarbose does not work inside the body. Acarbose inhibits the amylase enzyme and prevent the absorption of the carbohydrate. So I don't think that's a problem.
I'm
with
familiar with
metformin,
that.
yes, you're right.
It's the other stuff.
Right, the other stuff, that's true. But how much is going to take? 10%, 20% of those drugs? That's okay. It's because you want to have convenience there. If you separate them, then for the patients will have a hard time to compliance. And so there's many F and buts there. There's cons and pros. But I understand your concern, yes. And I think if Dr. Mike Emanuel was a pharmacist here, if he has anything to say, that would be great. But I know you're a pharmacist as well.
Right? Yes, that's right.
So, Dr. Mike Emanuel, what do you think about that thing about, is it significant or not?
We can try to add simethicone maybe to it to make it less problem. But activated charcoal, we get some good result for the gas also.
Very good. Anything else? I will move on to the next part of this segment.